I'm so honored to be here today, although celebrating 50 years of newborn screening. Although I was not a practicing audiologist 50 years ago, I was a practicing audiologist 40 years ago. And for 20 years, I identified children with significant hearing loss before newborn hearing screening was implemented in the state. So I've seen a huge range of changes. With my colleague, Dr. Martha Wilson, at Auburn University, we helped to implement the newborn hearing screening at East Alabama Medical Center with the assistance of one of the local ENTs, Dr. Bill Blythe. For the first 18 months of that program, Dr. Wilson and I, both audiologists, we did every screening, every hearing screening of every child. And we learned what I think all the nurses in this room already know, and that is that babies are born every day. They're born Christmas, they're born Thanksgiving, and you have to be there to provide those screenings in a timely manner. In addition to initiating the newborn hearing screening program, about 5 years later, I worked with the Alabama Department of Public Health when we started our doctoral training program at Auburn University for audiology students to set up an assistantship where our doctoral students would work at Alabama Department of Public Health to help to process the data that comes in from all of the hospitals. Lauren Cassidy, my co-presenter, is a second-year doctoral student at Auburn, and she is the Alabama Department of Public Health assistant. Also, for the past 8 years, I've been the director of the Auburn University Audiology Outreach in Guatemala project. We have partnered with the municipality of Guatemala City to provide a hearing health care program for children who are in the municipality and who are identified as very poor. Every year, a team of audiologists and doctoral students go with me to Guatemala, and we have set up a screening program, a follow-up hearing testing program, and we provide hearing aids to all children that are identified as needing amplification. Lauren was part of the 2015 team that went to Guatemala, and we benefited tremendously from her clinical experience and contributions. So it's a great honor for both of us to be here today, and as we look back on, it's sort of perfect that we're presenting together because I have this long history with the profession of audiology. I've seen the 50-year history almost myself. So I'm going to be talking about what's happened in the past and bring us up to the present. And then Lauren, who is the future of audiology, she's going to be talking about what's going on right now with hearing screening in the state, and then how we can continue to improve our programs, which is what it's all about. Audiology is a profession that's really dependent on technology, and there have been, like all of the things we've heard this morning, there have been tremendous changes in our profession and in our field, but mostly dependent on changes that have become available through the technology. I was looking back at 50 years, and I noticed that this is a little over 50 years, but about 59 years ago, that newborn hearing screening, there was a study done where they were actually using a cowbell, and they were taking a bell and they were shaking it over the baby and watching to see if the baby squinted. So that was 59 years ago, and things have changed dramatically since then. So how was a baby, Heather talked about, when she introduced the parents of the two hearing impaired children, she talked about how long it took before newborn hearing screening to identify a child. So I want to talk to you about how a child was identified at the beginning of my professional life back in the 70s. The primary reason for the hearing test was parental concern. Almost always it was a parent brought a child in and they said, usually my child is not speaking like other children his age. So you already know this is not a 6-month-old. This is probably not even a year-old. This is a child who's probably 18 months old, and they've noticed that they don't have the vocabulary of other children. The age of identification Heather talked about 2 years, 2 to 3 years was very common, so all of that language learning time had been lost by the time they were identified. The age of amplification, somewhere between 3 and 4 years. Sometimes, if you're really lucky, we'd get a hearing aid on a 2-year-old, but that was rare. The years in speech therapy, 5 to 8 years, and that's dependent on the severity of the hearing loss. With a profound loss, like the boys that were talked about, that Jennifer talked about, her 2 sons that had cochlear implants, those boys would be in speech therapy for the rest of their life, because they would always have to be, if they wanted to have good speech and language, they would always have to have a speech therapist monitoring what they couldn't hear and they were trying to produce. The typical adult reading level, 5th to 8th grade, and that's actually optimistic, average. The typical educational level was high school diploma. And that's very deceptive, because back in the 70s, if someone had a severe or profound hearing loss, generally they went to a school for the deaf. They would get a high school diploma from the school for the deaf. There was a paper published in the American Academy of Pediatrics in 1998 by Christine Yoshinaga Itano, and she reported that on average, deaf graduates from a school for the deaf with their high school diploma had the academic and language achievement levels of an average 4th grade hearing student. So they had that high school diploma from the school from the deaf, but they were educated, and their speech and language was at best the level of a 4th grader. So there were tremendous cost to society. So what would be the lifetime cost to society for a child that was born with a severe or profound hearing loss back in the 70s? This is a very complicated slide, and it's got lots of information on it. But I think the bottom line is that back in 2000, the Journal of the American Medical Association did a study out of Johns Hopkins University, and they indicated that the cost to society per hearing impaired child was $1.2 million, and that was 15 years ago. So tremendous cost to society, and a devastating cost to a child to be born with that hearing loss. How could it be 1.2 million? One thing is the cost of special education throughout that child's life, but even more important was a loss of income due to reduced work productivity. Let's talk about identification of hearing loss back in 1978. This is a true story. This is a child that I identified. The birth history, we've got twin boys born 6 weeks premature. One was bigger than the other, and the smaller twin, which I'm going to call twin A, required oxygen longer. There was absolutely no family history of hearing loss. The babies were healthy, beautiful, developed normally, but like many twins, they developed their own language, which is very common, where they talk to each other in a language that they seem to understand, but nobody else could understand. Now, in my experience, anybody who's had twins, parents of twins are pretty overwhelmed. I don't know if anybody here has twins, but I've got twins in my family, and my mom was overwhelmed with twins. But I have to say that the parents of these boys really had it together. I mean, they were bright, they were educated. The dad was an engineering professor at Auburn University. You know, they watched their kids. They knew they had this special language. They knew that was kind of normal. But at some point, they really started to worry about their speech and language development, and they brought them in to the speech and hearing clinic. So they brought both boys into the speech and hearing clinic. They were kind of talking like each other, and they were both found to have significant speech and language delay. They were enrolled in clinic, and initially the speech language pathologists, student clinicians, attempted hearing screening. These are 3-year-olds, and the boys were very uncooperative. But they said, let's just move right ahead and get them into speech therapy, which they did. We'll screen them at the end of the semester, and that recommendation got dropped. So that delayed further their working in their speech therapy, and it was not until twin B the bigger twin, the healthier twin, although right now when we saw them they were identical and they were both healthy, but the twin with less birth complications was making progress in speech therapy, and then the smaller twin was not making progress. So the hearing test was completed when twin A was 3.5 years old. Both twins were tested. The larger twin, the twin B, was found to have normal hearing, and twin A was found to have a mild to profound hearing loss. So this is for low-pitched sounds, he could hear okay, but for high-pitched sounds, he could hear nothing. So I want to play a demonstration of a simulation of how this child hears. Okay, so the board that you're looking at on the slide is going to be a simulation of hearing loss. And we found this online, but it's the Flintstones, which is a cartoon from back in the 70s, which is appropriate that we be using. It's Fred and Barney Flintstone, and they're playing Monopoly. Okay, you're going to hear 4 different simulations. The first simulation at the beginning is normal hearing. So that's a simulation of hearing normally. The second simulation is a mild hearing loss, and I think you will notice, gosh, it's not as loud, but I can understand everything. The third simulation is a moderate loss. It's going to be harder for you to hear that. The fourth simulation is what this child heard. Okay, that's what he spent all of his life hearing until he was 3.5 years old.
1, 2, 3, 4, 5, 6, 7. Aha! You're on my apartment building on Granite Avenue. You owe me $300. Get it up?
Fred, take it easy. It's only a game.
Wilma, I'm just like them big tycoons. I play to win. Now, Barney, pay up or get out of the game.
Busted. That's 1 down and 2 to go. Betty, it's your turn.
I don't have any more money either. You got it all.
Then I'll take a mortgage on your orphan's home.
Well, come on, take the bank, will you? Don't just sit there like a dummy. I will not have you talking that way to our guests. Come on, Barney. I think we'd better go home.
This is how this child heard. I mean, the very last piece was how he heard. So you can see why he wasn't making progress in therapy. You can see he was living in he had some auditory perception. He could hear loud things, which was another part of the problem. In a child that has pretty normal hearing in the low frequencies, but then it drops out, it's very distorted. But when somebody says, I think he has a hearing loss, and somebody claps their hands really loud, they'll hear that low frequency part of the clap, which they can hear, and they'll turn and look, and they'll say, see, he doesn't have a hearing loss. So it delays things. I also wanted to include this picture because the picture, to me, is a picture of an expression that, as a young clinician, I saw over and over. When I identified a child with a hearing loss, and when we put a hearing aid on that child, that was the expression that I saw on face after face after face. And it's sort of a combination of wonder and fear and awe and bewilderment. I mean, they have no idea what to do with all this sound that's coming in, and they've never heard it before. I wanted you to take a look at that. Just to finish up, so the difference in these child's life, the twin was amplified when it was 3 years, 9 months. That's very, very late, and there were a lot of reasons for that. Twin B, the healthier twin or the bigger twin at birth, was discharged from speech therapy at age 4. So he hadn't been making progress. He continued to make progress, and when he was 4.5, almost 5 years old, he was discharged from speech therapy. Twin A remained in therapy until entering high school. So again, part of that, and remember, these are great parents. They never missed therapy. They were in therapy twice a week, just as they needed to be. But at the time, in the 70s, the amplifiers that were put into hearing aids could not amplify the high-frequency sounds. So even though he was amplified, he wore his hearing aid all the time, he did not have access to high-frequency information. So it's hard to make a S sound if you're not, if you've never heard it before. So let's look back. Let's look back 50 years or 48 years at early newborn hearing screening. This is a screener. This was a screener that was produced in 1967, and I love this picture because it shows some very serious researchers. It's something that was developed that created a 90 to 100 dB sound, which is very loud, and it was a 3,000 hertz narrowband noise. And 3,000 hertz is a high frequency that's really important in speech and language development. So it was great. But what they actually did was, it was great that they were able to develop that. They would hold it over the crib, and they would produce this really loud sound. And again, it's not a cowbell, but they're looking for the baby to squint or react or something like that. They did a study which was reported. They screened 10,000 babies, and of the 10,000 babies, 150 failed. Of the 150 that did not react, 4 were found to have a hearing loss. So we know that we expect, somewhere between 3 to 5 babies per 1,000 to be identified with congenital hearing loss, and so obviously this technology missed a whole lot of that. We developed a timeline, and we've already talked about the cowbell, and we've already talked about the first hearing screener. In 1969, something very important happened. The Joint Committee on Infant Hearing Screening was formed. And this was a group of professions that came together. One was the American Speech and Hearing Association, which is our profession. The second was the at the time known as the American Academy of Ophthalmology and Otolaryngology. And the third was the American Academy of Pediatrics. And this group of professionals came together, and they came together in 1969, and it wasn't surprising that in 1970 they said that they did not recommend newborn hearing screening. They said there is not a procedure available that's appropriate. So even though that equipment had become available, they recognized right away that it wasn't good enough. So they did not recommend it. And that was really important in the United States that happened, because that hearing screener actually became adopted a lot in Europe. So hospitals purchased that equipment, they were using it, they were, and when you purchase and invest in equipment, you tend to like it, so they felt like they were doing what they could to identify newborn hearing loss. The United States did not. In 1972, the committee decided to take a different tack. Instead of looking at technology and trying to find something that they could actually screen children with, they decided, let's just look at what are the risk factors for hearing loss, and let's identify the children that are at risk for hearing loss. And I want to talk about those risk factors. So the high risk factors that the Joint Committee on Infant Hearing Screening came up with were, number one, family history of childhood hearing impairment, rubella, or any non-bacterial infections. If there was noted any defects of the ear, nose, or throat, this is a child that's at risk for hearing loss. Malformed low-set ears, cleft lip or palate, low birth weight, and a bilirubin level, abnormal bilirubin level. These were the first high-risk factors that were identified. They added to that, the Joint Committee on Infant Hearing has continued to meet. They continue to meet every year, and they continue to update. In 1982, they added bacterial meningitis and severe asphyxia, and then in 1990, they added syndromes known to include hearing loss and pulmonary problems. So they have continued to add to the high-risk registry, and it's really important that the nursery workers in this room be aware of the high-risk factors, the current high-risk factors. Lauren's going to be talking about what's current in 2015, but if you look back, if you think back on the baby that I identified, he had no high-risk factors. So even if they were saying, you've got a risk factor, you need to get your hearing tested, this child had no high-risk factor. In 1982, the Joint Committee on Infant Hearing recognized auditory brainstem response as a potential technology that could be very useful. So this was using electrodes and putting it on the baby's ear or the baby's head and measuring a neural response to sound that would be related to their hearing levels. Auditory brainstem response really came out of the University of California at San Francisco. A researcher there by the name of Jewett actually discovered this neural response. And it wasn't that much earlier. So this equipment had become available, and the Joint Committee on Infant Hearing Infant Hearing, said this would be a great technology. By their saying that, it really encouraged hospitals to look to that technology. And I've heard that because Europe had invested in this older technology, they were very slow to pick up ABR. And it's important to look back and to think what a positive impact the Joint Committee on Infant Hearing had on our country in terms of the identification of hearing loss. In 1990, the Joint Committee recommended that all babies with risk factors be screened prior to discharge from the hospital. And they recommended that all babies without risk factors get a hearing screening before they were 3 months of age. So it was really 1990, if you think, well, then that's all the babies, risk factors and non-risk factors. It was 1990 that the Joint Committee on Infant Hearing recommended that all babies should be screened. In 1993, NIH weighed in. So the National Institute of Health said, yes, we think babies should be screened, and the auditory brainstem response, or ABARE, is a great test to use. So at this point, hospitals really started looking at whether they were mandated or not. They were looking at the possibility of screening for hearing. In '94, it was recommended that all newborns be screened before they left the hospital. Not that that was happening, but it was recommended, and that the babies be screened by 1 month, they be evaluated by 3 months, and if amplification is indicated, that they be amplified by 6 months. So that's where the 136 came in. In 1995, I think the Joint Committee on Infant Hearing did a really important thing. They looked at the hospitals around the country that were performing hearing screening, that had hearing screening programs, and they brought them together to talk about what were their problems and how could their problems, how could this be improved. When I look at the problems that were identified 20 years ago, I think we still have to look at these problems because they're ongoing. We always have to, there's a lot of turnover in nurseries. We're continually having to re-educate and think about improvement. And I think we saw that with the awards. That was really exciting to see people saying, we recognize we had a problem, and by gosh, we tackled it. Now we have an award. Okay, so what were the problems 20 years ago? They recognize that intervention and management have to be an important part of the screening program. It's one thing to screen, but you have to really help. The hospital needs to help make sure that there's follow-up. Even if they're the initial seed that's planted, you're referred from this test, it's very, very important that you get this follow-up testing. The other thing is we cannot let parents be complacent and think, my baby passed the screening, the hearing screening, so my baby's not going to have a hearing loss. Parents have to be very careful in looking at their child's speech and language development. So always looking at if your child is speaking like other children. The Joint Committee cautioned that one of the biggest mistakes it could make, as these programs identified, was telling a parent that their child passed the hearing screening when in fact they did not. Because what happens is that I think we talked about earlier how hearing loss is invisible. So you can look at a baby, if a baby's born with a hearing loss, it looks like a normal baby. It looks like a normal 3-month-old. Looks like a perfectly healthy, adorable 6-month-old. It's not until they're 18 months old that they're going to notice speech and language problems. Parents suspect, because they spend they spend 24 hours a day with these babies, So a parent will often suspect, in fact, 70% of children that are brought in to our clinics for hearing tests is because of parental concern. And you heard all of the mothers this morning say, I had a gut feeling, I had a mother's intuition. You might have a mother's intuition that your baby's not hearing, but you want your baby to be perfect, and you're going to think, they told me, I'm worried about his hearing, but they told me at the hospital his hearing was normal. So you're going to tuck that away for 3 or 4 more months. And 3 and 4 more months of not being identified and not being amplified, now you've got a 2-year-old, and you heard about how devastating that is with the child that we identified in 1978. So those were all recognized as problems 20 years ago, but I think there's still problems today that we have to look at. In 1999, Pediatric Clinic of North America, which is a publication by the American Academy of Pediatrics, put out a publication. Their entire publication, every article was on newborn hearing screening. So that was a really seminal work in 1999, and that was what the final recommendation for universal newborn hearing screening in 2000 was taken from that document. So that's sort of a timeline to see how we got to where we are today. So in a few minutes, Lauren is going to talk to you about the essential elements for the detection and intervention of congenital hearing loss. But one thing that's really important to remember, especially for the nursery people that are here, is it all starts with you. You know, as somebody said earlier, first the baby's born, then we start to screen. You know, and the hearing screening, you are absolutely essential in making sure that that's done and that it's done right and it's done carefully and that it's reported. So now let's talk about identification of a child after our hospital implemented newborn hearing screening. So this child was identified when my colleague and I were still doing all the screenings. We do distortion product otoacoustic emissions. So this is that alphabet that Heather was talking about, and she said you were going to learn a little bit about it. So let me tell you, for those, I know some of you use this technology and already know what it is, but very simply, when you have a healthy hearing nerve and it actually hears a sound, then what is sent back out into the ear canal is an echo that can be measured. So it's an emission. So it's another way that a baby can be tested without having to cooperate or watch for any kind of behavioral changes. So for otoacoustic emissions, you put a little ear tip in the baby's ear. It's connected to equipment. It puts a sound in, and usually it's a screener, and it tells you pass or refer. That's what we were using at East Alabama back in 1999. We screened a little guy when he was 1 day old. He failed the screening, and then we rescreened him in the nursery the next day. He failed the rescreening. He came back to the hospital for a rescreen at the hospital, and he failed again. At that time, he was referred to Auburn University for a complete hearing test. The ABR, which was done at Auburn, was completed at 9 weeks of age. So this was really quick, and I think it was because partly because we were there and it was like, we got to get this kid in right away. So he was tested at 9 weeks of age, and he was found to have a bilateral, profound, permanent hearing loss. So this is the hearing loss that our parent talked about her second child had with Will, had basically no hearing. We made ear mold impressions so we could put those ear molds on him that were going to squeal a week later. We had ear molds made when he was 11 weeks old, and we delivered the hearing aids when he was 14 weeks old. So he was, a little over 3 months, which I don't know if that's ever happened again at our hospital, but it was just everything fell into place for this little baby. When we delivered his hearing aids, early intervention was there with us. So there were early intervention specialists who specialize in speech and language stimulation, and they were there to hear about how to take care of the hearing aids and to reinforce everything we said with these parents. They met with the parents, met with the family every month to talk to them about here's what you need to be doing for language stimulation. Hold your baby here. Make sure he can see your mouth. This is how you play with him to stimulate speech and language. So he really had everything that he needed. As our mother of the hearing impaired kids said this morning, you have to have a trial of a hearing aid for a certain number of months before you can be considered candidate for a cochlear implant. So this child wore his hearing aid until he was 1 year old. He was implanted at 1 and also was enrolled in auditory verbal therapy. This child received special ed services until he was in the 2nd grade. And I don't know if you can think back to the first child that I identified had speech therapy through high school. Probably never could learn as much as other children. This child is, just like that mom said this morning, when her child was 4 years old, they said, he's at the same level as normal 4-year-olds. So the fact that we can identify them early and also have the technology that is available, it just makes a huge difference in their life. So it's not just a saving to society, it's a saving to, it's an amazing, it's going to change these kids' lives. So I hope these two tales show you the dramatic difference between newborn hearing screening, before and after newborn hearing screening. There's no doubt that an effective newborn hearing screening program can be beneficial to a child, but only if the program is administered very carefully and if follow-up is completed in a timely manner. This is a slide about Guatemala, and I included it because my career has been educating students, and so I've always been clinical faculty member at Auburn through my career. And at the beginning of my career, remember the picture of the little boy, and I said it's fear and awe and bewilderment and amazement on his face. I saw that over and over as a young clinician. But once universal newborn hearing screening was implemented, my students never saw that. Because a baby gets a hearing aid when he's 6 months old, they never see that. So when I take students to Guatemala every year, where there is no newborn hearing screening program, there's no hearing screening program at any age, I have to tell them, I want you to expect this. You're going to see this. You're never going to see it here in the States, or I hope you never do, but you're going to see it over and over while we're in Guatemala. And to put a hearing aid on a 3-year-old or a 4-year-old, and it's just that, most of the time it's delight and amazement and fear, but sometimes it's crying, but it's just a shock because they've never heard until you turn that hearing aid on. So I've finished with the historical portion of this presentation. I'm going to turn this over to Lauren, who's going to talk about the present, what we can do right now to promote the hearing health and normal speech and language development of infants and children in Alabama. I'm going to go sit down.
Hello. It's a privilege to be here with you all today. I am the newborn hearing assistant at Alabama Department of Public Health. And I'm also the student whose grandparents came here today to support me. So thank you for that. But in addition to my role as the newborn hearing assistant at Alabama Department of Public Health, I also serve as a newborn hearing screener at Montgomery Medical Center, or Baptist Medical Center in Montgomery, and I was hired through Natus Peloton Services to do that. So I have hands-on experience both with inputting that information into the state database and also with administering the screenings to these babies and communicating the results to the parents and documenting them appropriately. So I really look forward to talking with you about a few aspects of newborn hearing screenings today and what our services, or how our services will impact these children as they grow into childhood and early adulthood. And most of the things that we talk about today will stem from understanding the importance of early identification and also proper administration of the tests, the screening, and proper documentation. So before we talk about the recommended protocol, before we talk about anything that has to do with how we're going to administer these screenings, I want to talk with you a little bit about prevalence of hearing loss just in the United States. You'll notice from these slides that hearing loss is actually fairly prevalent in our country. 2 to 5 in every 1,000 infants experiences a hearing loss in one or both ears, and 10 to 15% of newborns will demonstrate a partial hearing impairment that will be educationally significant. And so you may be thinking to yourself, well, how does this really apply to newborn hearing screenings? And that is a great question. It's really important to understand or kind of know or have an idea about the prevalence and how many babies we should be identifying each year in the U.S. Just to know how many numbers we'll have each year in babies who should be identified initially with a hearing loss. And for the state of Alabama, that's about 140 to 160 infants per year that should be identified initially with a hearing impairment. Additionally, when we see in numbers the thousands of children who are diagnosed with hearing loss per year, it just further justifies the need for early identification, that early identification process. And even recent studies have proven that even a mild hearing loss, we'll talk about the simulation in the next slide, again, the one that we just talked about in the previous slides, but even a mild hearing loss can cause detrimental effects educationally for children who just may have not heard the sounds that they're missing in an educational setting. So let's take a few minutes to refer back to that hearing loss simulation that you heard earlier in the presentation. You'll remember that the simulation takes us through a normal hearing, average hearing, and then it takes you into a mild, moderate, and then a severe hearing loss. And I'm going to play it again one more time for you just to take a few minutes to kind of fully understand and explain individually what each of these impairments in range of severity can do to a child educationally, socially, academically speaking, and kind of what that means for them for each separate hearing impairment. So let's go ahead and play that video.
1, 2, 3, 4, 5, 6, 7. Aha! You're on my apartment building on Granite Avenue. You owe me $300. Get it up?
Fred, take it easy. It's only a game.
Wilma, I'm just like them big tycoons. I play to win. Now, Barney, pay up or get out of the game.
Put on busted. That's 1 down and 2 to go. Betty, it's your turn.
I don't have any more money either. You got it all.
Then I'll take a mortgage on your orphan's home. Well, come on, take the dice, will you? Don't just sit there like a dummy.
I will not have you talking that way to our guests. Come on, Barney. I think we'd better go.
The mild hearing impairment isn't really that significant in comparison to the normal one. So the child probably isn't experiencing too much, or isn't missing too much, or it's not causing too much damage in an educational or social setting for them. And that may not be problematic for someone like you and I who had developed normal speech and language and who maybe acquired a mild hearing loss later on. Because we are linguistically mature. We have the capability to understand what someone is saying, even in an adverse listening situation. So if we're in a situation where ambient noise is happening, background noise is in the background, and we're experiencing a mild hearing loss, or even normal hearing, we're going to be able to use context clues to kind of understand what that person is trying to convey or communicate to us. We're going to be able to pull from different areas that we've already learned from, because we develop normal speech and language. Whereas a child with an initial hearing impairment, such as a mild hearing impairment, just simply won't be hearing those sounds initially at all. So it's just not the case. It's completely different for a child with a mild hearing loss. And additionally, as the child gets older and they're in an educational setting, they'll really be missing almost 50% of what's being done or said in the class because of all of the background noise that they're experiencing. Because in an educational setting, in kindergarten and things like that, there's children making noise, there's reverberation off the walls, there's different things happening here, and they're just simply missing the sounds because they're already having difficulty hearing them in the first place. So a minimal hearing loss can have a major negative effect on a child who needs to be able to hear the speech signal. And they can miss up to 50% of what's being said in the classroom. Additionally, they're predicted to be at least 1 grade level behind in comparison to their normally developing peers. So when we went through the simulation and we did the mild hearing loss, it went to moderate, which is a little bit worse than mild. And for a mild hearing impairment, the child can miss almost, if not managed appropriately, the child can miss almost up to 80% of what's being said in a classroom or in a setting where there is an adverse listening situation. And they're also predicted to be at least 2 grade levels behind by the time that they're in 4th grade. The last one you heard was the severe hearing impairment, and it is the worst one. Now, the mild hearing impairment can do just as much damage in terms of a child not understanding, but for someone with a severe to profound hearing impairment, it's possible that they just won't develop speech and language at all because they can't hear it. They're not hearing the sounds, they're not hearing the consonants, they're not hearing the vowels, and they just will not develop it normally. So that not only does major damage communication-wise, but they'll never be able to compete academically, they'll never be able to develop normal communication or social skills like those people that do develop normally. And they're also predicted to be extremely behind by 4th grade and have also behavioral problems because they just can't communicate what they want. So let's talk about our rationale for why we do newborn hearing screenings the way that we do them and why we use the recommended protocol that we have now in Alabama. So many of you have probably heard of the 1-3-6 rule, and that is identifying children with potential hearing loss by 1 month, diagnosing them by 3 months, and then fitting them or providing early intervention services by 6 months. This is extremely critical in ensuring that this child develops normal speech and language and is able to enter into an educational setting on time. This whole 1-3-6 process begins with us as screeners. We are responsible for identifying those children at 1 month with hearing impairment and getting them onto the necessary services that they need in order to develop normally and have that normal speech and language. So it really depends on us as screeners at first, and we're going to talk about later on the protocol that we use to kind of ensure that and to be confident in the results that we receive in the hospital and the ones that we're communicating to parents. So this is just a slide that has some really important factors on it, and I won't read all of them to you, but there's some really important factors that kind of are important for a child to be successful with a hearing impairment. So you'll notice on the very first portion of this, it says proper administration and documentation of newborn hearing screening. It's the very first step in ensuring that this child or infant receives the best possible care in order that they will develop normal speech and language and be able to have social interaction normally and compete on an academic level. So I know many of you have probably heard a lot about, speech and language, it's caught and not taught. And there have been recent studies that have shown that young children at a really, really young age can differentiate between two different languages. They can differentiate between like English and Mandarin Chinese at a really, really young age until they've developed their native language, until they've reached a certain age. And that just goes to show that children are equipped at birth to develop normal speech and language and absorb it at an extremely fast rate, beginning when the child is still in the womb. So just to be aware of that. And and on the slide it says all children with a hearing loss are able to develop spoken language primarily through listening rather than watching. So we heard earlier from a mom whose both of her sons had cochlear implants, and she talked a little bit about how hearing loss is silent. It's not something that you really see. It's not something that you're really aware of in most settings or in most cases, and most of the time you don't even notice if somebody's wearing hearing aids or not unless you really know them. So it is invisible. Most people aren't aware of it, but it can still be very detrimental if left untreated. And there's a clear distinction between hearing something and listening to something. So hearing is just that acoustic signal reaching the brain, reaching the auditory cortex and being processed as sound. Listening is when someone is intentionally attending to a speech signal for a reason, and interpreting that and utilizing it and applying it. So the sequencing of these events are extremely important. Hearing, access to that sound or that speech signal must come before the listening can ever occur. It has to come before they can learn listening skills. And when you think about it, what do you have to have in order to learn how to read, learn how to write, learn how to communicate properly and tell somebody what you want? You have to be able to listen and communicate. And in order for that to happen, you have to be able to hear. So that child has to have access to the acoustic signal and to sound at an early age in order for their brain to develop normal speech and language. So it says on the slide that children in a hospital that are appropriately administer newborn hearing screenings were 2.6 times more likely to have language within the normal range than those born in a hospital without a screening program. And we all know that within the first 3 years of an infant's life, those are the most important for speech and language development because this is when the brain is growing and rapidly developing, including the auditory pathway, and they're just absorbing everything that they hear, incidental language. Additionally, research studies have shown that children are born with certain areas of their brain that are specifically assigned to hearing. So if a child with a hearing impairment, no matter if it's mild, moderate, what it may be, if they go untreated, those areas of the brain that were initially assigned to hearing become reassigned, and they can no longer be reverted back once the child hits a certain age. So automatically, if that child hits age 5 or 6, then they're going to have an extremely difficult time not only acquiring the hearing sound if they're fit with hearing aids, but also being able to produce that sound and to communicate. So this is why, I don't know if many of you are familiar with cochlear implants that much, but if you go to fit an adult, say my age, with a cochlear implant who has never had access to spoken language or heard a single thing in their life before. They've just had profound hearing loss their whole life. If you go to implant someone with a cochlear implant at my age, they can never develop normal speech and language. They'll never be aware of what anybody is saying around them. It's more for auditory awareness, so knowing that there's a sound around them, but they'll never be able to interpret or understand what somebody is communicating to them verbally because those areas of the brain have already been reassigned to something else, whether it be ASL, some other medium of communication, and speech and language is just out of the question at this point. And so if we're not administering these newborn hearing screenings appropriately and getting that child intervention services on time, then we're responsible for basically rerouting a child's entire life and future. So let's talk about the recommended protocol. So it's used for all hospitals statewide when administering newborn hearing screenings, and there's 3 main goals of this protocol, and that is to screen all babies before discharge, to identify those with potential hearing loss, and then to refer them out for full evaluation, diagnosis, and intervention if it's needed. That's following that 1-3-6 model that we just talked about earlier, so identifying by 1 month, diagnosing by 3 months, etc. So let's take a look at this slide. The most important thing to remember for well babies who are in the nursery is that they should be screened no sooner than 8 hours after birth. You should not be screening babies before that 8-hour time period because that just increases the likelihood that your results will be invalid. And that just helps increase the reliability of the test results that you're presenting to both the parents and the state when that's uploaded. For NICU babies, I know that it'll be a little bit different just due to other pending health issues that take priority, but typically NICU babies should be screened just prior to discharge and after they have been taken off any antibiotics and oxygen. Babies who refer, but that's either NICU or well baby, need to be screened a second time in both ears and with the same equipment. So if the baby refers in either ear, it doesn't matter, the initial screening, they need to be screened again with the same equipment in both ears. After that second screening, is done. If the baby passes, that's great. You can communicate the results to the parents, and we'll talk a little bit about how we can do that more efficiently in a few slides. But if the baby refers, then they need to be scheduled for an outpatient screening in the hospital, and it's necessary to err on the side of caution when we're doing this. I know a lot of people, I have a lot of nursing friends, and they've told me from other states that they continuously rescreen baby more than the recommended 2 amount of times, and that's because they think, oh, well, the baby's probably fussy, or the baby is moving too much, and the movement is what caused the refer, because these testing equipment are so sensitive, and you have to have optimal situation in order to get the results. But it's really recommended that no matter what reason, if the baby refers, to just go ahead and schedule an outpatient screening. Even if you think it may be due to baby's fussy, baby's moving too much, whatever that case may be, just go ahead and schedule for an outpatient screening. And we're hoping that this will help us just double check that that baby doesn't need any further follow-up, and then also hoping to just decrease the load on you who are screening the babies, so you aren't having to rescreen so many times. So let's talk about the consequences of a false pass. So what's the harm in screening a baby until you get a pass result? We know that our equipment is extremely sophisticated, and it has a really good sensitivity and specificity rate, but it does still have some false results. And the more that you're screening those babies, 10, 15 times, whatever it may be, those can produce invalid results and not reliable results on their hearing screening. And in the event that you do get a pass result, it's not a valid outcome to really report to the parents or to the state in general. And ultimately, it's doing the family a huge disservice, because they'll believe that their child does not need follow-up anymore, and that's coming from a hospital or healthcare entity. And if the child does in fact have a hearing impairment later on, they'll just think to themselves, oh, well, the hospital said that my baby passed the initial follow-up screening, it's probably nothing. And that could further delay the process of intervention, which is not good. And we just want to make sure that each baby is being seen and getting the appropriate amount of results that they can, because we have the equipment, we have the technology, and we have the resources to ensure that they get normal speech and language communication. So let's talk some about risk factors. I'm sure many of you in the room are aware of many or all of these risk factors, especially in relation to other health issues. However, it's good to refresh ourselves on what to look for prior to discharge concerning hearing loss as well. And it also may be beneficial when explaining the results to parents and to the state. And it could also be a contributing factor if you do see unsatisfactory results in the initial or second rescreen. So these are the risk factors for hearing loss at birth. So those are the babies who, these are risk factors for babies who could have congenital hearing loss. So those are the babies that we will be screening in the hospital. That includes stigmata associated with a syndrome known to include hearing loss, family history of permanent childhood hearing loss, craniofacial anomalies, and in utero infection, including CMV, herpes, toxoplasmosis, syphilis, and rubella. These risk factors here are primarily associated with NICU. So we really want to be sure to document these. Even if the baby does pass their initial screening in the hospital. So say baby passes this screening in the hospital, but they do have some NICU indicators saying that they are at risk. It's important to communicate that to the parents, but also to the state, so that we know to follow up with that baby and send home a letter saying, hey, we'd really like to reevaluate your son or daughter based on their risk factors. These are risk factors for a late onset or progressive hearing loss, and And they're also important to document. So you may see a well baby and you may say, oh, the baby passed their initial screening, and you send it home. But if the parent has any concern, or there's a postnatal infection, including bacterial meningitis or any other syndromes associated with progressive permanent hearing loss, it's essential that you document these and send them out to the state so that we know to follow up with that baby, even though they had nothing else that was initially wrong with them. And here's some additional risk factors for late onset or progressive hearing loss. So this, in closing, is going to be the last thing that we talk about today as far as newborn hearing screening. And this is probably one of the most important things, is communication to the parents. So we did have a video earlier, but we had some technical difficulties, so we won't be able to present it. But I'm going to go ahead and explain to you what exactly was on the video. Initially, there was a woman who came on there, and she acted as if she were about to screen the baby's hearing, and she went through the case history with them, and she went through some other questions that may be pertinent and associated with hearing loss, such as family concern, family history of hearing loss, those types of things. But then it also went through and gave you basically an example of how to present a pass result, how to present a refer result, and then also how to present a pass result with risk factors, and explained it to you. And we also have the script if any of you think that that may be beneficial to you when talking to the parents about their baby's hearing, especially if you get a refer. I know a lot of us don't want to have to be the bearer of bad news and tell the parents, especially of a newborn, that their child did not pass the initial or even the second screening. But what I recommend is to just reassure them that this is a screening. It's not an actual test of hearing. That screening just indicates that your baby needs further follow-up, and that in order to get further follow-up and in order to develop that normal speech and language ability, it's crucial that they get in to that outpatient screening and get the services that they need, and just ensure them that if they take the right precautions and follow the steps that we're asking them to follow, that their baby will be just fine. Thank you so much.